And good afternoon. Today we're going to talk about a particular form and technique for providing psychiatric consultation to primary care practices in rural locations. Now, my day starts at St. Joseph Hospital, moves to the Penobscot County Jail. I do collaborative care consultations with rural hospitals and then with Aroostook Mental Health Center and Wellspring. And it's a mix of seeing patients one-on-one, but most of my work is in consulting with primary care teams. Now, today we're going to talk about something called AIMS, AIMS, which is Advancing Integration of Mental Health Services. And this is a project that is 21 years old now out of the University of Washington. I happen to have attended the University of Washington, which is the medical school for 5 states: Alaska, Wyoming, Idaho, Montana, and there's one other one. But they were relying upon the university for mental health resources for these rural states with small communities. And they developed a program called the Collaborative Care Model, which uses psychiatrists in an entirely different way. They use psychiatrists to participate in primary care teams, where the teams assess the patient, see the patient, present a case to a psychiatrist, who then writes a manualized or standardized consultation note with recommendations, and then primary care physicians write the prescriptions, and then our case management does scheduled follow-up. Now, I'm going to give you a number that you may not believe, but in this program, which now is in over 200 communities in the northwestern United States, one psychiatrist, 4 hours a week, working with a primary care panel organized as I will describe, can manage the mental health care for 5,000 patients. 4 hours a week, 5,000 patients. It's incredibly effective. This is evidence-based, and we'll walk through some of the evidence. And I think some of you may know that there was a major virus attack on computer systems in Bangor and across Maine last week, and I don't have our system was affected, and I don't have access to my slides. But with Jonathan's indulgence, I'll be glad to send out the slides later on. So I want to start with a quote from the Wall Street Journal, and this Wall Street Journal quote was from 2013 to give you an idea how long this technique has been used. And it's authored by a reporter named Melinda Beck, and it says, Seattle psychiatrist Anna Ratzliff oversees mental health care for nearly 500 patients, most of whom she will never meet. As a consulting psychiatrist for 4 primary care practices, Dr. Ratzliff confers weekly with care managers who follow their patients closely, providing counseling and chart their progress in electronic registries. She helps devise treatment plans and suggests changes for those who aren't improving. I get to touch so many more lives than I would if I were seeing these patients one-on-one in person, she says. The article goes on to say that Dr. Ratzliff's practice is part of a burgeoning effort to integrate psychiatric care into primary care practices in a bid to make more efficient use of a limited number of mental health professionals. Some practices are using new ways to deliver more care to more patients at less cost. Now, when we think about integrated mental health care, the common caricature is of having a nurse practitioner or psychiatrist on site in a mental health practice. What this does is quickly fill up the 16 appointments a day, and the backlog continues. It doesn't really meet the needs of a large practice. By using the team-based approach and collaborative care model, as I said, the many more patients can be managed. The model works something like this. A primary care practice panel, 5,000, 10,000, however many patients, or 500 patients, identifies a care manager. The care manager can be a mental health professional, they can be a nurse, they can be a care manager, and every patient in the practice is screened using the evidence-based tools of a PHQ-9, the Personal Health Questionnaire 9 version, the GAD-7, and in some cases the BSDS, the Bipolar Screening Disorder, Bipolar Symptom Screening Disorder set. The patients who score at depression levels or anxiety levels at 15 or above, that would be 15 out of 27 on the PHQ-9 depression scale, or 15 out of 20 on the anxiety scale, meet criteria for medication treatment. The consulting psychiatrist has provided, as part of this program, algorithms and medication recommendations that then primary care can implement for the people who score above 15. The evidence base is that medication should be re-examined every 12 weeks and patients should be rescored. If they continue to score above single digits, either medication dosage changes or medication changes are made. And then after each review of each case, a standardized progress note or consultative note is provided that goes in the patient chart for the primary care team. So what this involves is identifying in a medical practice who has symptom profiles and symptom burden of illness at levels that require or benefit from medication. Then the medication is recommended, it's prescribed by primary care, and follow up in 12 weeks. And the outcome year over year to this type of collaborative care is actually superior to that of having on-site mental health professionals. And overall practice scores, the burden of illness for depression and anxiety, are reduced. So I've covered a summary of a program that's been around for 20 years. Let me stop and ask if there are any questions or any of you have any familiarity with this approach to team-based psychiatric care.
I had a question, Dr. Schaefer. Do you have copies of these algorithms that you could send out?
I do, and they're also available on the website. The website is the full training. Because it's a federally funded program and evidence-based, there is a University of Washington website that has every bit of material that I'm presenting to you. And let me just find the link here. And again, I'll send these to Jonathan. If you go to aimsuw.edu, you'll find the program, and so you can print off the copies yourself. There's summaries of the principal medicines used in mental health treatment, and the dosages and the treatment frequencies and all there are part of the program. Now, every case that's presented to a psychiatrist gets a note, and these would have been sent to you, a single-page note that is standardized across the nation, that involves, that talks about the topic, the presentation, the provisional diagnosis, the recommendations, and the medication dosages. So the primary care receives the note and then acts upon it and writes the prescriptions, and then the case manager schedules follow-up in 12 weeks. Any other questions or comments so far? Have any of you worked with collaborative care? Now we have, this is being used, to my knowledge, only in northern and eastern Maine. And in our group, we have about well over 2,000 cases that we've worked with over the past couple of years. But what I want to try to do today is not to do anything except to encourage you to think differently about behavioral care in the primary care setting. There aren't enough nurse practitioners. There aren't enough psychiatrists. And the one-on-one 30-minute or half-hour visit per patient is no longer feasible. But the evidence base proves that the one-on-one visits are actually no better in a large practice panel than the collaborative care. And depression scores and anxiety scores decrease more rapidly and with larger decreases using the collaborative care systematic model than one-on-one treatment and follow-up. The way it usually works is that a care manager in a primary care clinic, having had all the patients surveyed, has identified the patients with the most prominent symptoms and the highest scores. They then triage those and present those to the psychiatrist in a scheduled period of time, and then get the treatment plans and consultative notes back, usually within the same day or the next day. Questions so far? The difference here is, again, that a psychiatrist leads a team. The team is presenting patients based upon evidence-based criteria and self-reported symptoms. Think about how difficult it is to go through and ask all the questions of your patient about their mental health. The PHQ-9 has the 9 criteria for depression. The patient can score the severity of each of their symptoms from 0 to 3. And it is self-reported. There's not the problem with lack of interpretation, lack of listening. The same with the anxiety score. So you've got patient-reported data using evidence-based measures that then guide and document treatment. And the plain fact is that most behavioral health care does not require psychiatrist treatment. Most behavioral cases do not require psychiatric nurse practitioner treatment, that they can be managed with consultation in the primary care office. Now, an additional part, especially in the parts of Maine that we all work in, is transportation and appointment compliance. One of the reasons that none of the mental health providers have offices in the peripheral areas anymore is the no-show rate. You can't get people to keep their appointments for all sorts of reasons. Things like snow, things like lack of transportation, things like substance use that has cost them their driver's license. But they can get to primary care. So this gains access to psychiatric care without transportation, without another appointment, without the referral process that you have to go through, and makes it accessible to many more people. I think the hardest thing for people to move away from is to think that mental health care has to be delivered across the desk or table or across the video. Video mental health care is useful for full psychiatric evaluations, but again, it's the one-on-one, time-intensive, very expensive model for delivering health care. Now, this model has been evidence-based, and again, it'll be in the slides, for depression, anxiety disorders, PTSD, and also in dealing with comorbid mental health symptoms for diabetes, cancer, and heart disease. There are more than 80 randomized randomized controlled studies that demonstrate this, and the outcomes most recently for this kind of collaborative care compared to on-site collaborative care are superior. One other way to look at this is population-based healthcare. We're treating an entire practice panel, not individuals. And we're all beginning to be evaluated on our success in managing our overall practice, not just how we do with individual patients. If there are no questions here, I'll walk through a couple typical cases that we get for primary care. But Jonathan, let me just pause for a moment and see if there's any people that think this is a terrible idea or have questions or specific issues.
I just have a question. I don't think it's a terrible idea, but where does the liability lie with the team approach where there's lots of hands in the pot? I see that, and unfortunately medical legal is a thing. So where does the liability lie if there's a consult physician, a primary care provider that's prescribing, and a care manager who's assessing?
The liability in any consultation goes with the person who implements it. If you call for a cardiology consultation, a neurology consultation, gastroenterology, it's up to the person who's with the patient to either accept or reject the consultation, and the liability's there. The difference is instead of just a telephone consultation, there's the evidence-based model for this. There is the consultative note that accompanies it. There's the measurement process that just doesn't occur outside of this process, but ultimately the liability lies with the primary care. And let me give you another example of this. There's the myth that televideo in the emergency room relieves the emergency room doctor of responsibility for a psychiatric case. That's absolutely not true. It doesn't do anything except mostly get an opinion on whether or not they meet inpatient criteria. The liability is still with the treating physician, and I think that's true across all consultations.
So we know many of our medications can take 6 to 8 weeks to work. What is the rationale for meeting with people only every 3 months? Is it lack of time or something else?
It's not meeting with people every 3 months, it's rescoring them.
Oh, okay, I understand.
So let's say somebody comes in with a depression score of 17 and an anxiety score of 19. The medication algorithms identify which medications might be appropriate. Their care manager has access to allergies and treatment failures. Recommendations are made. And one of the worst things we can start doing in primary care is medication switching after 2 weeks. Unless there are clear side effects or adverse events, 12 weeks is the evidence-based trial. That's considered a full trial of a psychotropic medication. So the rescoring. Now, part of the recommendations may be weekly therapy. They may be monthly checks, but you don't make a medication switch generally until the 12-week score. Let me go through a couple real cases here within the past few months. And this is a consultation for a 55-year-old follow-up, and the topic is depression. In preparation, and again, this is a stylized note that comes out of the protocol. So we have a patient name, location, medical record number, date of birth, requested by, topic depression.
And Dr. Schaefer,
yes.
Actually, so are you you're transitioning into the two case studies kind of that you had sent over?
Yes.
Okay, I just want to make sure. I did actually receive those as you were talking, and so I did email those out to everybody that's on the call right now. So I don't know, anyone who's able to check their email, you may have gotten a PDF that contains these two kind of formulaic case summaries.
Okay.
I think
can I walk through them verbally?
Yeah, I mean, in trying to, in keeping the kind of the echo mind frame, I don't know if it's possible for these, if you feel like if we have the ability to like look at them one by one, and we'll do is kind of give it an overview of that first one. And then we can do is open it up to the floor for some clarifying questions about this kind of case. And I'm assuming that these cases are already complete, right? They have a resolution.
Yes.
And I didn't get a chance to look through them because they just came in. Is that kind of given, the resolution given in these summaries?
I can tell you the outcome, and I did not provide the follow-up note. I presented the presenting note.
Okay, perfect. Yeah. So if we look at the presenting note, it's almost we'll kind of frame it up, and then we can do questions, and then we can also do some reflections and kind of recommendations of how the group would possibly work through this as a case, and then you can give us kind of what happened, and we can reflect on that and do them one by one. That might be the best.
Well, let's start. There's a 55-year-old and a 53-year-old. The 55-year-old, here's the case. With depression and neurocognitive impairment that had been inappropriately labeled as demented. They had an untreated depression. Recommendations, we walk through the ways to make diagnosis and to treat the depression, and there are specific medication changes recommended, and this patient turned out not to be demented. but in fact was depressed with neurocognitive impairment. Very, very common. And the teaching of this is there are lots of things besides medical illness that can cause depressed mood and impairment, and vice versa. So, do you want me to walk through the presentation, or just open this to questions after people look at it for the 55-year-old?
If you want to, I mean, if you just kind of give like a 1 to 3 minute verbal kind of summarization walkthrough of that first one, and then we'll open it up.
This patient, we reviewed this was profiled by the practice, and I reviewed office records, notes, medication records for the past few months. Poorly controlled diabetes, microvascular disease, large vessel disease. You see the uncontrolled hemoglobin A1C, and it was on one antidepressant at full dose. It's been getting worse quickly, experiencing confusion, and an evaluation was performed in yield diagnosis of vascular dementia with refractory depression. But if you look at the symptoms, it's no energy, worthlessness, rumination, hopelessness, no history of seizure disorder, no substance. And the provisional diagnosis was that this was major depressive disorder with cognitive impairment. And the recommendation is it's unfortunate that any patient would receive a diagnosis of dementia concurrently with, paired with a diagnosis of refractory depression. Before we give somebody the D diagnosis of dementia, it's important to rule out psychiatric illness. As you know, giving a dementia diagnosis changes the family, it changes the outlook, it changes everything. And what we wanted to do was to change the medications to manage what was in fact a treatment-resistant depression. We used low-dose antipsychotic as an augmentation agent. We used stimulating antidepressants, and we tapered out the ineffective full-dose sertraline. Patient got better. I don't know that they ever took the dementia diagnosis out of the record, but the patient regained function and was able to return to a substantial portion of their life. And I never saw this patient.
So do we have questions? It looks like Dr. Abroya, we do. So yeah, let's open up to some questions regarding the presentation.
Sorry, my question isn't appropriate. I was asking about logistical issues, so I'll save that for another time.
You plan to, well, did you plan to use Abilify indefinitely, or did you just want to use it to stabilize symptoms quickly until Wellbutrin started to work with the plan to eventually titrate the Abilify?
The STAR-D depression study, the largest study of depression, recommends Abilify, low-dose Abilify, along with either low-dose risperidone for treatment-resistant depression, which is depression that has failed to respond to 2 full-dose completed regimens of antidepressant. So there's a possibility that this patient will be on Abilify and bupropion over some period of time. This was not just a kick in the pants kind of effort, and that would be determined in follow-up and subsequent measurements.
Do they provide you with the past medications tried or the past trials? I'm just wondering if there were any other typical antidepressants that were tried.
They ran, on this case, they ran with sertraline all the way up to the maximum limit. There was no report in the record of other antidepressants. But they did provide us with that information.
Any other questions from our participants and or our faculty regarding this presentation?
Um, I picked these two cases because both of these cases would have normally involved a filling out a referral, sending it to a psychiatrist in Bangor or another. They're really, let me think here, there are one, sometimes two psychiatrists in Fort Kent. There's one psychiatrist in Presque Isle. There are no full-time psychiatrists in Washington County. There are 1.5 psychiatrists in Hancock County. So Bangor basically is where most of these people would have to be sent. A referral, an appointment, transportation, report, follow-up, all that. And we were able to give this, as you pointed out, maybe unexpected treatment that would not normally have been available in primary care. It's not usually it's not usual for people to add low-dose antipsychotics to help with treatment-resistant depression. But with this consultation, with the documentation, and with the follow-up, it made state-of-the-art psychiatric treatment available in a remote location. The second case is similar, and this is a case with a augmentation that got a fellow back on his game. And this is we all have these in our towns, a local well-known character, picker, handyman, tipper, raker, all that. And he's known as being edgy, and he's got some legal problems, and he's been in the practice a long time and is a curmudgeon. People still love him, even though he's a bit of a pill. And the fact there are some funds available to pay for his medication. He's got these stressors in his life. He's not able to work. He's fading in his hygiene. He's more disagreeable than usual. Sleeps more than usual. And he's got some expectations that aren't being met. He's got some multiple medical problems. He's got diabetes and obstructive sleep apnea, been on fluoxetine and gabapentin. And we did find that he had treatment with multiple antidepressants. And the best choice here was to augment what he was already on with a low-dose antipsychotic. And it worked. Again, risperidone 1 milligram on top of the fluoxetine was able to interrupt his ruminative thinking. It jump-started the fluoxetine, and he was able to return to his normal level of curmudgeonness and productivity. And again, this is a case that would not have been, there was no way he was ever going to travel the 90 miles to Bangor for an appointment to get this level of treatment. You'll also notice in the recommendation that it's on everything on here is on the $4 list at Walmart. And we work really hard, and the list of medications available, you'll see, encourages the use of generic medications. And we seldom make recommendations for the new generation antidepressants or antipsychotics. And this is another way to be cost effective and to help people with limited financial resources to manage their care.
Peggy, I see you're back with us. You're on mute right now.
Can you hear me?
I can. So please jump right in. I think we lost Peggy again, though. Either that or she's sitting very still.
While we're waiting for the signal from the Freiburg Fair, I'm not intending to recommend that we add low-dose antipsychotics for every depressed person. What I'm demonstrating is, attempting to demonstrate is that consultation using this model provides primary care practices with ways of assessing the burden of mental illness in their practice using the screening scores, of identifying in ways that have never been able before the burden of illness and where to focus your mental health efforts. Having somebody on point, whether it's a nurse or a social worker or an LADC or somebody who coordinates the cases, who then makes presentations using this evidence-based protocol to a consulting psychiatrist, and then getting consultative notes which guide therapy according to evidence-based protocols, the 12-week protocol, the remeasurement. And it allows hundreds and potentially thousands of people in Maine to receive the benefit of mental health consultation inside their primary care practice. We'll send out the slides, the website. This is not proprietary. There are now fellowships in collaborative care psychiatry being offered in psychiatry residencies. The state of New York has recently begun to implement collaborative care by mandate in some of their most rural counties. There are, I think, at last count, I think there are less than 60 psychiatrists in the entire state of Maine. I gave you a little rundown on the some of the rural counties. The state of Illinois has, I think, Chicago and all the environs. The state of Illinois has 302 psychiatrists. Most of those are based in Chicago. So they also are moving to sponsor and subsidize and to encourage the use of collaborative care in the state of Illinois. This is something that will change over the next 5 years. As I mentioned, the fellowship training, the funding, the training that's offered to psychiatrists already in practice. This is a way of the future to deal with shortages that are going to continue. So, Jonathan, that pretty much was everything I had hoped to communicate. Anything else that I can offer here?
I mean, I think just, I don't know if the group wants to open it up kind of free for all and just either ask questions, make some comments or recommendations on this type of model, whether you've been able to utilize it or hope to utilize it, in the future. I know definitely attending some of the health conferences and the technology, utilizing Zoom now to be able to really democratize the knowledge and obviously share these best practices and these resources across huge states that are very rural, and is going to be key to the future of healthcare, I think. And just anyone have kind of comments or questions on what Dr. Schaefer has talked about?
I had a question about where do you see the role of nurse practitioners in this model? You speak a lot about psychiatrists and the dwindling numbers, especially in rural counties. Where can nurse practitioners fit in?
They can receive the training and they can begin to do the model. It's available to people. It's a 12-hour basic training. Certification is available through the website for the case managers, and they're an important ingredient as well. So if a psychiatric nurse practitioner were to complete the training, the certification, and the feel comfortable to begin to use these models, they can participate as well.
Other comments or questions? Or examples even where you've been able to utilize some kind of telepsychiatry or these types of models with patients?
Jonathan, I want to make sure that people are clear that this type of collaborative care is different than televideo, different than telepsychiatry. Telepsychiatry is one-on-one. If people want to do this by video, I can consult. I have consulted with teams using the video, but one-on-one consultation in primary care for mental health is generally not required. And we need to move our thinking away from whether we send them by links to sit in an office one-on-one or whether we have them sit in front of a computer one-on-one. Those days are no longer feasible. Likewise, putting nurse practitioners or psychiatrists in primary care offices or circuit writing is no longer feasible. Most mental health issues can be dealt with successfully in primary care with support.
I don't see anyone else, and I mean, I do know we all have busy days, and we have lots to do. So I'm not going to keep everyone past the time unless anyone else has any comments or questions, or just in general. Dr. Abram?
Dr. Schaefer, thank you. I had a quick question. So how much time is the primary care physician spending on the written consult request that's being sent to you?
They spend no time. The patient is identified by the screening tool, and the care manager has the medical record, and there's a standardized presentation the care manager makes to the psychiatrist.
Okay.
For the really complicated cases, the primary care may want to make the presentation themselves.
Okay.
It actually turns out to be quite uncommon. It's usually the care manager that does this. So there's no written preparation. There's a standard protocol. You'll see it on the UW website for what elements are needed. Some primary care want to talk, others, but most of the time it comes through the care manager.
And then how much time are you spending on chart review and documenting your recommendations?
Depends on the sophistication and of the program, how long they've been in it. We can handle between 4 and 10 of these cases in a scheduled hour. It depends again on the mix of the cases, the severity, and the familiarity with the program. Usually we do 4 or 5 cases and documentations in an hour.
Thank you.
Right, and welcome. It looks like Kelly joined us a little late. Welcome. We'll make sure you get the recording, the stuff you missed.
Yeah. Jonathan, I'll just close with a couple other points. And I do have to head off because I consult for an hour using collaborative care with Heuristic Mental Health. We use this in county jails. We use this in emergency rooms. We use it in nursing homes. And in the community-based crisis services. Once the team becomes familiar with the tools and the techniques, it allows us to provide psychiatric consultation across a number of venues. Thank you for your interest, and with that, I'll return you to your regular programming and head on to my consultative hour.
All right, thank you, Dr. Schaefer. And so you'll get in touch with me though as far as materials, correct? You said some of those links.
Yeah, the links and the slides will come when our system's back up.
Perfect.
Thank you.
Thank you. Have a good day. So with that, if there isn't any other final thoughts, I'll also let you all kind of get back to a few things before the start of your afternoons. So I will be sharing out the materials, the recordings from today. Hopefully I'll get Dr. Schaefer's slides as soon as I can, and then get those as well out to everybody. Thank you all faculty for joining us today, and thank you for our participants. It looks like we have Kelly and Lori, or Kelly and Christine. So thank you so much for your dedication to the program. If you have any other, colleagues that would like to join and jump in with you from your organizations as well, please feel free to extend that welcome to them. And other than that, if there's anything else, I wish you guys all a great day. And we'll see you back next month on the 7th of November for our 5th session. Bye, everybody. Take care.